Bismillah ar-Rahman ar-Rahim, alhamdulillah rabbil alameen, salatu salam Sayyidina Muhammad. I'd like to thank the organizing committee, and I'd like to thank them actually for giving me the hard part of this debate. I'm glad you said the older, because old is gold. Is that right? So actually, there is no winner or loser in this debate. The only winner is the patient. And we're gonna actually show you the evidence, and only the evidence, in my talk about the usefulness of JAK inhibitors over anti-TNF and maybe other biological DMARDs. So the first question is, do we need a new medication with different mode of action or mechanism of action to treat RA? Well, the short answer is yes, because it's not always successful to achieve low disease activity or remission with current treatment options, and this is what we call it difficult to treat rheumatoid arthritis. We have a problem with drug survival. Patient preferences. Some patients, they prefer oral versus subcut injection or IV. And of course, we have always an issue with the availability of the drug and some regulatory constraints that they favor or they push you actually to use one mode of action before the other. So let's briefly go through this actual definition of difficult to treat. So the EULAR defined difficult to treat rheumatoid arthritis as patients whom have failed at least 2 or more biological or targeted synthetic DMARDs, in addition to conventional synthetic DMARDs who have actually active disease. And actually, several studies have addressed this prevalence, and the prevalence actually in several studies it varies between 5 to 10%. So 10% of your patients with rheumatoid arthritis are difficult to treat and already have failed 2 biologic or targeted synthetic DMARDs. This is a systematic review and meta-analysis of drug registries and healthcare database to assess the proportion of RA patients actually who discontinue biologic, and here it's anti-TNF, in a world registries and healthcare databases. And they have actually included more than 200,000 patients. And look here, if your patient, 52% of your patients on anti-TNF, they will actually discontinue the treatment at 4 years. So that means 52% of your patients have failed anti-TNF for whatever reason. So that's why we actually, we are blessed to have more mode of action. So we were happy in 1998 when etanercept was FDA approved. And now actually in 2012, we have the first JAK inhibitors approved by the FDA, and followed by parasitinib and then upadacitinib. And as you're aware that tofacitinib actually targets JAK1 and JAK3, and to a little extent JAK2. Parasitinib target JAK1 and JAK2, and upadacitinib is mainly JAK1 inhibitor. So what is the role of JAK inhibitors in achieving clinical remission? Well, all these clinical trials, no matter what RA patient's profile you have, whether the patient is treatment naive, methotrexate inadequate responders, biologic inadequate responders, or failure, then all these clinical trials actually have shown efficacy, even superiority over anti-TNF alpha. And let me take you to the first study actually, where they compared tofacitinib monotherapy 5 milligram twice daily with methotrexate. And here, no matter what, no matter how early or late your patients with early or established RA, actually 5 milligram twice a day of tofacitinib was equally effective. And that's actually different than what have been published with anti-TNF, especially with very early RA, the response is better than early RA. But actually tofacitinib here showed that there is no difference and superiority over methotrexate, and that was not actually proven to be that anti-TNF is superior to monotherapy, superior to methotrexate monotherapy. Now let's talk about those patients who have inadequate response to methotrexate, and this is the oral strategy for tofacitinib. Clearly the primary endpoint was met, where tofacitinib 5 milligram twice a day plus methotrexate versus adalimumab plus methotrexate showed non-inferiority, okay? Now, in terms of remission, actually there was equal outcome or equal effect between the tofa 5 milligram twice daily plus methotrexate and adalimumab plus methotrexate. When we come to the baricitinib, this is the RA BEAM clinical trial, again in patients with methotrexate inadequate responders. The primary endpoint was achieved, and the predefined endpoints for bari versus adalimumab in terms of ACR20 change and the change in DCR and change in DAS28 CRP at week 12 showed superiority as well. But again, when it comes to remission, bari was equal to adalimumab. The story was a little bit different when they used upadacitinib, and upadacitinib actually plus methotrexate was superior to adalimumab plus methotrexate in all remission outcomes, as you can clearly see here. Do we have a pointer on this one? Huh? في pointer? ما في pointer? طيب يا جماعة, this is very important والله. طيب, the effect of upadacitinib versus anti-TNF was actually extended beyond that, and it shown superiority over abatacept plus methotrexate in those who have no response or inadequate response or intolerant to biological DMARDs. So you can see here that the clinical remission at 12 weeks or at 24 weeks, there is a superiority of upadacitinib plus methotrexate over abatacetinib plus methotrexate. So JAK inhibitors clearly have shown us that use tofa or other JAK inhibitors plus methotrexate at least as equal as anti-TNF, if not superior to it, and to other non-anti-TNF biological DMARDs. Now, what about the effect of patients' reported outcome? Now, remember that what patients care about is pain, and pain drives 80 to 90% of their decision when you ask him how much would you give, how much you rate yourself out of 10. Pain contribute to 80 to 90% of their decision. So what is the effect of JAK on patient-reported outcome? Clearly, baricitinib, how can I go back? Okay, baricitinib and upadacitinib clearly have shown significant greater reduction in pain versus adalimumab with methotrexate at 4 weeks and up to 52 weeks. So what about compliance? Is compliance of patients different between JAK inhibitors because it's an oral agent and other biological therapy? Thank you, Dr. Amer, for this publication. So this publication was done by Dr. Amer, and clearly for 1,300 patients, more than 1,300 patients, clearly there was no difference between JAK inhibitors and biological DMARDs. And at here, I'd like to stop, and I will ask my colleague, Dr. Amer, to come and enlighten us about other biologics, and then I will continue.